I'm really looking forward to hopefully demystifying pain a bit for you and to talk about pain care. It's a subject that I really enjoy talking about. And so I really hope you get something from our time together this evening. But before we start this presentation, I'd like to invite you to join me in a grounding exercise. Now, this is something that's often part of psychologically informed practice and something that you might like to try with patients and on your own at some point. So please take a moment to find a comfortable position, and you might like to close your eyes for this. You might even want to turn off your camera, whichever you prefer. And this short grounding exercise will help you transition from your day and your evening so far to help you arrive and be present in this space. So I invite you to bring your awareness to your breath as it enters and leaves your body. Notice how your body rises and falls as you breathe in and out. Now I'd like you to bring your awareness to your feet, how they are resting on the floor. And bring your awareness to your calves, your thighs as they rest on the chair, your bottom, your spine, your shoulders, your arms and hands. Bring your awareness to your face and your neck. And notice as you breathe, as your breath enters and leaves your body. As this short practice is coming to an end, bring yourself back into the present moment. Maybe have a stretch, open your eyes, and maybe just take a moment to consider how you're feeling just after this practice compared to when you arrived here this evening. So I'm just going to turn on my slides. Oh. So I've worked as an outpatient physiotherapist for about 22 years, and a grounding present moment body scan is not something that I would have ever considered doing with patients when I started working. I've worked in lots of different MSK departments in different capacities, and I've spent a lot of time doing different rotations, being a clinical lead and extended scope practitioner. But all the way through, I've always wondered why some people that I've worked with get better and the pain that they experience goes away, and then in others, the pain continues. I did a MSK Masters at King's, which didn't really answer my queries. And since then, I've been on a bit of a quest to find out more about pain and pain care. And so now I work at St Thomas's Hospital in London, but not in an MSK setting. I work in a pain management centre called Input, which runs pain management residential courses for people experiencing persistent pain. The pain management programme is a non-medically led programme, and it's based on psychologically informed practice on a psychological framework called acceptance and commitment therapy. But I also spend time working on my own, where I also combine my traditional musculoskeletal therapy skills of manual therapy, exercise, and movement analysis with pain care. And I don't believe that one or the other should be practiced. I believe that physiotherapists can practice in a very psychologically informed way while still focusing on physical health. And I try very much to use the biopsychosocial model so that I bring together the body and mind when I work with people. So over the next 45 minutes or so, hopefully you'll learn a little bit more about the complex nature of pain. And we'll see how integrating the biological with the psychological and social factors can help the way that you work with people who live with pain and experience pain. And we'll talk a little bit about the psychologically informed practice and what it is and how it's being used in clinical practice. And then a little bit about what I believe pain care involves and why it matters as part of your practice. So I guess you know that pain care is important, otherwise you wouldn't have given up your evening to listen here. But just to reinforce what you already know, there are a lot of people in the world and in the UK that live with chronic pain or persistent pain. So regardless of what area of physiotherapy you're working in, whether it's neurology, respiratory, oncology, surgery, you will come across people that will be suffering from long-term pain. And this is why I think it's important that we have an understanding of how to work with this group of people, and that have the skills of what I call pain care, because it'll come up everywhere that you work. So what is pain? Now, I believe that pain means different things to different people, and the meaning of pain is very different to whether you're a health professional or not a health professional, whether you've experienced pain, whether you've not experienced pain, whether you used to experience pain. And I think we will all have a different understanding of its meaning and its purpose. And I imagine that even here tonight, pain will mean different things to different people amongst all of us. And I think it's important to remember this when we're working with patients and colleagues. Because pain is complicated and it can be influenced by many different things. And I've come to recognise and understand that it's an experience that's in our bodies, in our mind, and in the environment around us. And this diagram is one that I adapted from an article that's been written by two musculoskeletal physiotherapists. And I think it's really helped me, actually. And I think it's really helpful because it reminds me that I need to consider lots of different factors when I work with somebody, so that I can help work out what's relevant to that person and what is important to that person, so that I can create a good working relationship, a good therapeutic relationship with that person. And it may also highlight things that may be barriers for us working together as well. To bear in mind too, that not everything is relevant on this diagram to everybody. And this slide here shows a diagram that shows, that's fairly self-explanatory, I guess. It shows the peripheral and central nervous system in relation to pain. And I've given all sorts of different explanations to patients about this. And for some people, it's really helpful, as it can help them reconceptualize their beliefs and understanding of pain and what's important or what's happening in their body. But then on the flip side, for some people, it doesn't seem to be all that helpful. But regardless, for me, I think it's really helpful to bear in mind these sensitization processes that happen peripherally and centrally, and also the changes that occur in different areas of the brain, because it reminds us that the body and the mind are connected and both are part of the pain experience. I think it's also helpful to remember that some of these changes are all normal and they happen within the nervous system when there's been an injury. And so we would expect that as healing happens and the changes in the nervous system settle down, that pain goes away. But as we all know, pain doesn't always go away. And sometimes pain isn't always linked to an injury. And to be honest, a lot of the people that I work with, in fact, probably most of the people that I work with, don't experience pain that is a consequence of an obvious injury or trauma. And this is where pain obviously gets quite complicated. I think in situations when pain doesn't settle the way we would expect, or when pain doesn't happen for an obvious reason, I think it's helpful to just keep in mind what the differences between acute and chronic pain are. And I think this is really useful when helping people understand what's happening in their bodies. And so helping people to reframe their beliefs and understanding about pain. But I think it's not as simple as this in some ways. It's not always black and white. So if we think about the purpose of pain being there to protect us, it's to help keep us safe. It helps us survive if there's an infection in our bodies. It alerts us to harmful changes in our body in the case of cancer or other things. It alerts us to avoiding something dangerous, if you might burn yourself on a hot cooker, or if something's damaged. like a broken bone or a sprained ankle. So pain is really helpful in its acute stages. It's really helpful and necessary if we have a broken leg, as it protects us from further damage and allows us to heal. And we would usually expect that it would disappear as the body heals, and so protection is no longer needed. And usually we would expect healing takes less than 3 months, about 3 months usually. Some things take much less time to heal, and some things take a bit longer. So it does depend on context, and that we have to take into account. But in the case of persistent pain, what is its purpose? Why is pain helpful, or is it helpful if the injury has healed or if there's no pathology obviously seen in investigations? What's going on? So in some contexts, I think it can be considered that persistent pain isn't terribly helpful, and it isn't really serving an obvious purpose. But I also think it's still a sign that there is a need for some kind of protection, and that it is considered some kind of warning sign for something that's not maybe normally or usually associated with pain. And so it might not be necessarily associated with a problem in the body's tissues. For example, it might be more related to stress or fatigue or maybe diet. So again, pain depends on context and the story around the experience. It doesn't always link to ongoing tissue damage or non-healing. And in fact, it might be considered that it's less to do with the injury or tissue damage and more to do with the nervous system. Some people liken it to be that like the volume knob on the pain system has been turned up. And generally we term persistent pain as pain that lasts longer than the expected recovery or healing time of sort of 3 months. And I think this is a really helpful and good opportunity to discuss this with people, to reassure people who live with pain that if we're encouraging them to perhaps do some movement or some activity or some exercise, that this won't be harmful to their body, this won't be damaging. So if we consider that pain is the brain's impression of whether protection is required, but do our brains always get this right? Does pain always mean that there is tissue damage? So the X-ray on the left-hand side of your screen is obviously an X-ray of a foot and a nail, and the nail going through the foot. Now this was taken of a guy that worked in a building site, and he stood in a nail, and he was in an awful lot of pain. He was in excruciating pain, as you might imagine when a nail goes through your foot. So he went to the A&E department and they x-rayed him, and they saw the nail in the foot. And they gave him lots of pain medication. And the pain medication helped, and his pain levels settled. So they took his shoe off to have a better look at what was going on. And they realised that the nail wasn't in the foot. It had passed through between the toes. So there was no tissue damage. The nail wasn't in the foot, and all was rectified after that. The next slide X-ray shows a nail in somebody's head. Now this was taken of a construction worker who was working with a nail gun, and he was doing a job with it and never noticed any problems while he was doing the job. But about 6 days later, he began to get some toothache, and he began to get double vision, blurred vision, I think it was. So he went to seek some medical opinion. I'm not sure where he went, but he went to seek some medical advice, and they took an X-ray of him. And this was when the nail was found in his face. But so there would have been tissue damage there, but no pain at that time anyway. And the third picture is of somebody who has had his forearm amputated. I don't know, maybe you've heard of phantom limb pain. And that's when the limb has been removed and amputated, most likely due to a pathology, and most likely that pathology would have had pain along with it. And so you would kind of think that if the limb that was painful was removed, you would no longer experience pain. But in the case of people that suffer from phantom limb pain, the limb and the pain is still felt. So pain is always real, but is it an accurate predictor of what's happening within the body? From the book Nail Guy, we know that pain can occur without an apparent physical cause. And from the Nail in the Head Guy, we know that there are times that pain doesn't occur despite injury. And from our understanding about phantom limb pain, we know that pain often persists after the affected body part is no longer there and healing has occurred. So pain is always real. No one can tell somebody that they're not experiencing pain, and it's always real to that person, but it isn't always accurate in telling what's happening in the tissues. Pain doesn't always equal damage or injury in the tissues, but we have all been encouraged to believe that it is, which is very confusing and unhelpful for us and patients alike, I think, anyway. Most patients won't have considered that their brain is involved in pain when they're experiencing in the pain that they're experiencing. But some people find it helpful to learn about the body and the mind connection. And I think validation that the pain they experience is real and not all in their heads or made up is really important as part of creating a good therapeutic alliance. And I really like this diagram, which is from the Live Well Pain website. It explains about persistent pain in a gentle but clear way and highlights what's going on in the brain that might explain why pain persists. So it highlights, while there are physical reasons, the sensitization of the nervous system and genetics for ongoing pain, there are also psychological and social reasons. The fear, the memories, your mood, the life experiences and sleep. All of these processes and things that are happening in the brain lead to the ongoing persistent pain rather than what's happening in the tissues. And I'm sure you will all have come across this definition of pain from the International Association of the Study of Pain. And maybe you're cleverer than I am, but it took me quite a while to work out what this definition means. And to me, the definition emphasizes the subjective and multifaceted nature of pain that includes the sensory part through the nervous system and the emotional part through the feelings and thoughts. And it also highlights that pain can be experienced even if there is no tissue damage, like the man with the nail in his shoe or someone that has phantom limb pain. So when something that's perceived by the brain to be threatening, this can cause a pain experience within somebody. So there are several main models of health. The biomedical model is the model that is most prevalent in our Western society. And it focuses health solely through biological factors. And it kind of considers the body as a machine that has identifiable parts that can malfunction and go wrong. And with that, it tends to exclude the fact that there are social and psychological factors that also influence illness. It's very much led by healthcare professionals who are seen as the primary experts that diagnose and treat illness through different medical interventions. And so that kind of makes this process very hierarchical and doesn't often consider patients as having answers. And it doesn't always even involve patients with their treatment. So there isn't an equal partnership between the patient and the clinician. It's also very focused on trying to cure the disease by addressing the underlying biological causes rather than perhaps managing symptoms or promoting overall well-being and quality of life. Now, I think our physiotherapy approach, our sort of traditional way of working within musculoskeletal physiotherapy, follows this biomedical approach because it follows the focuses on the physical and sensory aspects of pain. Now, we are physiotherapists, so we should be concerned about the physical health of the person sitting in front of us, and that's just right. But I do think that with our focus on physical health and screening for red flags and thinking about investigations and physical objective tests, sometimes the psychological and the emotional and the social aspects and influences of pain get overlooked and maybe even missed out. And I often think they're definitely considered less important. I've found that our assessment and treatment sessions are often quite structured and quite scripted. Now, in my early career, I definitely liked having a good structure. I found it really helpful, and it helped me a lot. But I sometimes think it can limit how we see and understand the person as a whole that we're working with. And I think that sometimes working in this rigid way doesn't always achieve a good therapeutic working relationship. And I often think that because of the scripted nature of the sessions, they're very focused on physical components, which can be helpful and obviously are really important because we are physiotherapists. But again, it might just mean that some of the details and the more sensitive information and seeing the person as a whole and understanding them, they may get overlooked a little bit. Not purposefully, but they may do, which kind of leads that sometimes we might be working a bit dualistic and separating how the body and the mind works. And when we focus on physical pathology or dysfunction, I think often we've ended up focusing on trying to fix or cure the problem. And so our ultimate goal of treatment is reduction of pain. Along with that, there's often pressure to provide answers and solutions to everything, which that doesn't just lend to more of a hierarchical relationship rather than it being an equal partnership. It's also quite stressful. Puts quite a lot of pressure on us, and for some people can lead to distress and burnout. And in my experience, sometimes this approach doesn't always work for people. It doesn't always give them the answers and the things that they're looking for. But when I started to slow down and become less focused on the red flags and the tests, now I still do them, I still include them as part of my treatment, but I became perhaps less focused on them. And I really tried to understand the person in front of me. I relaxed. I enjoyed my time much more with those people, and I got a much better connection, and I think probably better outcomes from the session as well. So in sort of roughly 1970s, a guy called, an American psychiatrist called George Engel, he began questioning this biomedical model of healthcare, and he proposed a different medical model called the biopsychosocial model. So this model's been around for a while. And as we've already highlighted, that pain is an experience that involves sensory, emotional, cognitive, and social aspects, this biopsychosocial model has helped us broaden our understanding of pain and approaches to pain care. But in my experience, within musculoskeletal departments, orthopedic departments, and medicine in general, even though there's a lot of talk about the biopsychosocial model, I'm not terribly sure that it's always fully applied. And I think it's really hard to do it in the circumstance, in the systems that we work in and the way that we work. So it's not anyone's fault. It is a difficult and complex model to apply to people. I think often there's more priority still put on the biological side of things and not so much the psychological and the social aspects. Now, when we're considering the biopsychosocial model and sort of working out how it's relevant for the person that we're working with, these are some questions that I sometimes ask people. And I ask them along with the routine, perhaps script questions. So I might change my words a little bit from the script that I would have used in the past. And there are some biological type questions, and then obviously some psychologically related questions and questions about the social situation. But I think what's important is finding your own words to find out this information. These are just ideas that I've done and I've tried, and they sometimes work for me and sometimes they don't. But it is important, I think, when you're trying to delve into the psychosocial questioning a bit more, that you find questions that work for you and that you're comfortable with. So while I still very much use my traditional physiotherapy skills, and so should you, I have a proposal of maybe trying something different along with your patients, along with these physical skills. And maybe some of you are using these already and you're not aware of that you're using these already. But it took me a wee while to work out what psychologically informed practice is. And my understanding of psychologically informed practice is that it's a framework that gives us as physiotherapists who are not psychologists and haven't been trained in psychology to work with, so that we can still apply our physiotherapy skills and knowledge, but at the same time focus and identify and work with the psychosocial factors of pain. And so we support people living with pain and persistent pain in a very holistic way. It's a practice that draws on and uses different psychological frameworks, such as acceptance commitment therapy, cognitive behavioural therapy, mindfulness, along with perhaps acceptance commitment therapy or its own entity, motivational interviewing, compassion focused therapy, and you'll probably find that different pain management programs use different components of these therapies to make it work for whatever it is that they are wanting to provide. And I think having a framework is really helpful, because ultimately our jobs are, we want to help people. We want to facilitate behaviour change with people. People have come to us with a problem. They're not able to do things that they want to do. So we need to help them do that so they can live the way that they want to live. And I don't think we were ever given or certainly I wasn't, when I was training, ever given a framework as to how to do that. And I don't think I was ever given a framework helping me understand why it was difficult for people to make those changes. I mean, let's face it, we all know that we want to perhaps make changes within our lives, but it is hard. So having a framework has helped me do that with people. But at the same time, I go back to the fact we're not psychologists, but we do need to understand people as human beings and not as machines. And so understand their moods, how they're feeling in general, and also their thoughts and feelings around the pain they experience to help them fully. I also appreciate that practicing psychologically might bring about concerns. You might not feel you have the skills, you might not feel you have enough time, you might not want to open a can of worms and be able to address the problems that the person has told you about. And you're right to have concerns, because you have to work within your scope of practice. But there are lots of good people, lots of people on the PPA, as well as lots of other people who are very keen to support and help you. There are loads of websites, podcasts, books, and courses that you can learn more about all these different frameworks and try something from them. It doesn't have to be adopting the whole framework, just maybe a few things to start with. I think the interesting thing is that there are underpinning themes with all these frameworks. And the sort of main themes that underpin the frameworks that stand out to me are having a good therapeutic alliance and working with people on their values and with meaningful goals. And so implementing psychologically informed treatment strategies and techniques offers the promise of improving patient care for people living with pain. So as I just mentioned, a big component of practicing in a psychologically informed way is to try and create a good therapeutic alliance with the person that you're working with. And this refers to the relationship between the clinician and the patient. But I don't think this should be reserved only for people working with people that experience persistent pain. And I think I think the importance of this is often overlooked. In my training, it certainly was. So it's about helping people feel safe and confident to make decisions about making changes in their life, which ultimately we're trying to help happen. And it's also referred to as a therapeutic relationship, and it's to do with the sense of collaboration, warmth, and support between the client and the therapist. Ultimately, we need to try to create a safe and trusting space to help the person you're working with to share and tell their story. And we really need to get to know the person and really understand them, and so understand the patient's whole pain experience as best we can in the environment that we work in the structure we work in. This is not easy. We need to try to understand the impact of pain that they experience on the physical, the emotional, and the social components. And one way of doing this is to be curious. Try and see the person in their context, in their situation, and don't be frightened to go a bit off-piste sometimes from your usual script and structure. Acknowledging the pain experience through their story, through validating comments with empathy and compassion. Saying things perhaps like, I understand that being in pain has a huge impact on your life, or it must be hard to live with your pain all the time, I think are really important to acknowledge the struggles that person that you're working with is going through. When I learned a bit about motivational interviewing, I learned a bit about reflections and affirmations, and that helped me reflect to show my understanding of whatever it was that we were talking about, and that I was really listening to them. Now, sometimes I didn't quite get it right. So even if I had misunderstood something, it was an opportunity to understand it properly. And that obviously helps with better relationship and hopefully better outcomes of the treatment sessions. And working like this all lends to working collaboratively and finding an equal partnership, which means that things are done with a person and not to a person, which so often happens in healthcare and within physiotherapy. As part of all of this, I also think it's important to bring awareness of yourself and how you are within the therapeutic space. And this is hard. And whoever said our job was easy, I don't know if anybody has, but it's not true. There's so much to consider and think about. So part of developing a therapeutic relationship and creating that therapeutic relationship is understanding the impact that pain has on the person that you're working with and the impact that pain has on their life. This also helps us understand what barriers there might be for recovery for that person and helps us focus on what really matters to that person and what we might work on together. So there's so many aspects that need to be considered as part of ongoing pain. And I believe that there's always something that we can help with. So asking someone about how pain impacts their life is an important question. As physiotherapists, I think you can narrow it down to how pain impacts them physically, because I guess that's what we're there for. primarily, but I think it's still important to know about how it impacts them emotionally and socially, because as we said before, it all works together. And you can see from this slide that the pain is the tip of the iceberg. There are a whole load of other things underneath experiencing pain and having pain that aren't so obvious. And to be honest, I don't think I did consider all these other things when I started working, but they do play a part in ongoing pain and sensitization of the nervous system. These questions on the slide are sometimes ones that I ask people, but again, it's a case of finding questions that suit you and in your own words. If questions are quite difficult for you, then this the picture of the iceberg is on the Live Well with Pain website as well, and you could give it to somebody as a worksheet and do it together, and they could maybe identify some things on that sheet that might be helpful for you to work on and help you understand that person better that you're working with. So this slide is a summary of things that I've learned over the years that have helped me, or what I think anyway, to help me create a good therapeutic alliance with the people that I work with. I sort of considered it within verbal communication and non-verbal communication. I think about the session style and structure and how I am within that session. How am I feeling that day before I go into that session? What am I bringing with me? And how do I work with that? And then spending a bit of time after the session as well. And not just thinking about the things that didn't go well, thinking about the things that did go well, because you'll all be doing a good job. And I think there's obviously part of how you write that up as well that can help with reflections on your time with people too. So another part of psychologically informed practice is considering patients' values and their goals in their life. So as I said earlier, ultimately our role is to help people change their behaviour so that they can do what they would like to do and live a life that is meaningful for them. And another part of psychologically informed practice is identifying what matters to that person with pain. And this can be done through considering their values in life and helping the person identify goals that really matter to them and motivate them. And values and goals are not the same. Values can be described as principles that guide and motivate us through life. They represent what's important to us and shape the way that we want to live. And they describe how we want to behave on an ongoing basis. So we all have our own set of values and there are no rights or wrongs. But in physiotherapy, I'm not sure that exploring values is something that we would do regularly. It might not be something that you've done before, but you might like to use it to help identify meaningful goals with somebody. To make sure we're following values and making our life rich and full and meaningful, we need to put them into action. And goals are quite a good way to put values into action. Goals represent specific things that we would like to achieve, and they're usually associated with our values and they have personal relevance and meaning to us. For example, I have a strong value about health, and as part of my health value, I practice yoga quite regularly, and I wanted to do a headstand. My goal was to be able to do a headstand. So now I can do the headstand, so I'm quite pleased with myself. So I've achieved that goal, but my value of health is still there and is still ongoing. So once the goal is completed, we might want to work on something else, or we might not. Sometimes in life, we lose track of our values. There might be a significant life event, or maybe we have developed chronic pain, and these take us off track from our values. And so it's really important to help people remember what their values are and what's important to that person, so that they're able to return to a life that's meaningful for them. And meaningful goals are maybe an alternative to SMART goals. It helps them find something that is important to them and what they identify with and what matters to them most. And a way of asking somebody is, what matters to you? What matters to you today? And that's a question that I often ask people. In saying all of this, sometimes I don't set goals with people because sometimes it's not helpful for them if they're already quite goal orientated, or sometimes I just ask them, what would you like to get from coming to physiotherapy? As simple as that. It very much depends on the individual and the context. But these are some ways that I find out about people's values and goals. These are some questions that I ask them. And again, I come back to finding words that suit you and you feel comfortable with. So we as physiotherapists are very much part of the future of pain care. We're already there as part of the present day pain care as well as many other people and other organisations. And at the beginning, I mentioned the difference between pain care and pain management, and I haven't really talked about pain management at all. This is because I don't really like the word management. To me, I think it's really uninspiring and implies that nothing can change. It's a bit like treading water. And I don't think this is the case for people that live with long-term pain, because our bodies are always changing. Our nervous system is neuroplastic. Our tissues are constantly remodeling, so it's always changing. And to me, this means that there's hope for change for many people. I never know and don't know what that means to the level of pain that somebody's experiencing. But if you can help the person you're working with to open up and try something new so that they're able to do the things that they want to do and their quality of life gets better despite experiencing ongoing pain. And I've seen this many times, so I know this happens. This is amazing and this is brilliant. And offering hope to someone is so important. So I think pain care is a much more encouraging term. And I think it involves, and we can't separate these, this is the whole thing. It involves what I'm calling psychologically informed practice framework, thinking about the therapeutic alliance, thinking about meaningful goals and values, doing what matters, being compassionate, validating the person, and drawing from psychological practices of acceptance commitment therapy, cognitive behavioral therapy, compassion focused therapy, motivational interviewing, and combining with what I'm calling clinical skills, clinical aspects. Now, as I say, they're not mutually exclusive, they go together. And some of these clinical aspects you're probably doing already. So in a way, you're probably already practicing psychologically informed practice. And there are other things that you might want to add to your toolbox in time, whatever you're interested in. And I don't believe that there isn't a distinction between physiotherapy, MSK physiotherapy treatment and pain care. I think there's a continuum that moves backwards and forwards depending on the person and what they need and what they want. Some people will have a more complicated story to tell, and some people will have a more simple story to tell. And this will influence how you work with them. But regardless, the whole person needs to be considered, not just the body part that they might be quite focused on. So pain care shouldn't be limited to people with chronic pain. It isn't something that's separate, that happens on pain management programs in a separate building. It's part of every clinical encounter that you will have. And it may even, who knows, prevent somebody from developing persistent pain. And I think having more pain care type skills in your toolbox is a type of self-care, and it'll help with your stress levels and your levels of distress and even burnout. Your job is really hard, and what you do is often underestimated, and it shouldn't be. It's really complex and demanding. So maybe trying something new, trying a new question, trying a different kind of way of working might make things a little bit easier for you. So I've reached the end of my presentation, and thank you very much for listening, and I hope you found it helpful in some way. I think we've got a bit of time for questions now, and Carol and Charlotte are going to take them. But I just wanted to finish with, I became a member of the PPA a few years ago because I recognised that I needed a bit of clinical support, and it's been really great. The PPA executive team are a really experienced, knowledgeable, supportive team of people who are very keen to spread the word about pain care and help clinicians in their roles. The events they run are great, and there's some coming up in the near future, and to join isn't all that expensive. So I do think it's worth becoming a member, particularly if you work on your own or you don't have enough or much support at work. So thank you very much for listening. Thank you.
Thank you so much, Hannah. That was fantastic. I think really insightful and empowering, I think, for students that are learning about these type of concepts from, and when you start in practice, and I think even 5 years on, like myself, just having that refreshing, like you said, things are always changing and approaches are changing, and like you said, changing our questions and how we are. So it's yeah, that was absolutely great. Thank you so much for sharing that. We've got a question from Dom, and the question is, I'm interested to know your thoughts on the links between chronic pain and neurodiversity and why higher rates of pain are reported in this population.
Oh, now now that's a question to start with. Where will we go? There are high links, and I might need to come back to you on that question to give you a good answer. I feel a bit stumped, but Camille is waving, so she maybe will be able to help me with it.
Hi, good evening, everyone. Yeah, I'm happy to jump in because I had a bit of time to think about that question, Dom, which is really, really valid, really important. But yeah, we kind of start to dig a bit further in the topic of pain when we come to that. Oh, hello, my cat. I think when it comes to neurodiversity and pain, there is some new research emerging that is interesting. I think it's really to acknowledge there's a lot that is unknown at this stage. But what we do know, or what we can imagine, is that living in a world that is not designed for your needs, living in a world where it's really difficult to interact with other people, to understand yourself, and living in a world where just everything is really challenging because of your neurodiversity, experiencing stigma as well, and repetitive stigma, repetitive struggle to access services, all of that are threats. And we know how threat is massively affecting the experience of pain. This is my cat's first Zoom meeting. She loves it. And the other thing we know about neurodiversity is on a more biological level is interoception. And we know that in this subgroup, the ability to feel your body can be enhanced, and people can have really strong experience of feeling emotions, and that also can take part in the pain experience. These are just some thoughts. I'm definitely not an expert, but that was to drop some ideas. I hope that's helpful.
That's great. Thank you very much. A question from Millie. So she's currently working in NHS MSK clinic and has seen a number of chronic patient and fibromyalgia patients who often report poor sleep quality, which impacts compliance to do their physiotherapy exercises. What would you recommend to support people with improving sleep quality, or how would you advise your patients on this?
I've got different thoughts going through my head with that. So thank you for your question, because I think regardless of whether people have a diagnosis of fibromyalgia, I think people experiencing pain for any reason, sleep is a big thing and a big problem. And I think there's different reasons why sleep is often interrupted. And I think this is the curiosity and asking people about their sleep and really drilling down about what it is about their sleep that's difficult. Is it getting to sleep? Is it in the middle of the night? Is it related to pain? Is it related to, a lot of people are also disturbed by their thoughts in the middle of the night as well, and that struggles people struggle with going to sleep. So there is lots of information about sleep hygiene out there, which can help people. So helping people think about the simple things about having a bedtime routine and phone use and what people drink and eat before going to bed and what they do in the middle of the night if they are awake. But I think also this might be generalization, but I've met a lot of people who have been diagnosed with fibromyalgia often are people who are on the go all the time. So they're quite busy. They're keeping going. They try and push on through. And I think part of sleep and recovery is talking about that. And so helping people slow down, helping people have time to relax, and well, relax is difficult, to find that recovery restorative time so that their body gets a rest from everything that's going on. So it's maybe that's not sleep, but at least it's restful, and that seems to help a lot of people. So coming at it in different ways, I think. I hope that answers your question.
Like you said, that's quite like I said, complex, isn't it? There could be lots of to explore there, definitely. Time for the last few questions and then some updates at the end. So is the CFT approach, which incorporates the biopsychosocial principles, effective in treating MSK-related chronic pain, especially low back pain? Additionally, Hannah, do you have a personal experience using this approach with a patient that you could share with us?
I missed the approach, sorry.
The functional therapy approach.
Cognitive functional therapy, as in the Peter O'Sullivan's approach. I have used bits of it. I think my practice is that I kind of take what I fancy from lots of different people and make it work for me over the years. So I can't say that I've exactly used it as part of it, but part of my practice, but I like it because it fits with how we work. That's maybe not answering your question. Could you say the question again, Charlotte? I don't feel like I'm answering that very well.
So is it effective in treating people with MSK chronic pains?
I think it does. I think it has a framework, which I think is really helpful. So yes, I would say it and I guess it define effective. It depends on what the outcomes are. But I think it gives a good framework and structure, and it helps understanding the person. It helps looking at the person in a very physical, biological way, but understanding their cognitions and their feelings at the same time, and helping people get back to doing what they would like to do. That's my understanding of it, and certainly that's how I use it. So yeah.
Brilliant, thank you. And Carl, did you want to add on that question?
Yeah, I was going to jump in because obviously cognitive functional therapy is quite fashionable at the moment. So going back to the effectiveness, so I think there is a big clinical trial called Restore trial from Peter O'Sullivan. So basically they show that there is a significant effect, and it's a low cost treatment for people with chronic low back pain. So there's evidence out there. But in practice, I did similar to Hannah, so I did use part of it. So I think the key element for cognitive functional therapy, so they are underpinned by CBT, cognitive behavioral therapy approach, and the key is validating patients' experience and then try and reframe their experience into a less negative experience, and then try and help them in that way. So obviously there might be some patients that this approach wouldn't work, but maybe worth trying with some of the patients. And personally, I find the communication part of it is always very difficult, because in the cognitive functional therapy, they actually need the clinician to have a high level of skills in terms of using the approach. So that's why I think whether or not the approach is useful is one thing, and I guess they are now into now we know that CFT is probably very helpful for some of the patients, and how can we enable the clinicians to use that approach? So I think that's the sort of the next step for cognitive functional therapy.
That's amazing. Thank you. And for everybody's